So this is a radiograph. It was picked up by my colleague Art Stillman, and yeah, so it was a recent radiograph. You can see all these interstitial opacities here throughout the lungs, even some curly B lines. And so this is 2020, and this is a CT from 3 years ago. And here again on the CT, the notable thing is the interstitial opacities. And I didn't include other. There were several other radiographs in the interval between 2017 and 2020. They're all the same interstitial opacities. There are no pleural effusions. Normal heart looks pretty much normal. So this is, and he's had a patient. She's had a biopsy here. This is a patient with Niemann-Pick disease, and basically it's a lysosome storage disease, and it's a systemic disease where they have deficiency in the enzyme that breaks down sphingomyelin, and that accumulates, and then in the lung findings it gets taken up by macrophages. So you have a lot of fatty macrophages, lipid-laden macrophages in the interstitium. Here's a nice AJR article. It's very nice and concise from 2010 on Niemann-Pick, and they talk about the different imaging manifestations. And obviously it's multi-organ. And essentially all the other organs outside of the lungs, the findings are very non-specific. So for example, in the spleen, it's just splenomegaly, or in the liver, it's hepatomegaly. In the lungs, it's this the interstitial opacity, just like we see in the example. It's essentially the same pattern that we see in the example.
Yeah, I've seen a couple cases of this as well. It looks exactly like it, and Gaucher's disease can look like this, and also congenital lymphangiectasia. That's a nice example you have.
Mm-hmm. And unfortunately, the biopsy was done years ago and somewhere else, and and I wanted to look at it, but didn't have access.
Yeah, I think it's anytime you see kind of chronic septal lines, I think storage diseases are always a good thought. Amyloid too.
Okay, this one, let's take a look at, this is just a fun quick one. This radiograph, just kind of interesting looking peripheral, very dense consolidation in the periphery. It's not pleural effusions, it's pulmonary parenchymal. Here's a chest CT. So this is very recent, from a week ago, this chest radiograph, and then the CT from a few weeks ago, which corresponds to this radiograph. So there's this diffuse consolidation. Doesn't really fit the pattern of any of the diffuse lung diseases that we know, or the interstitial lung diseases. So, but if you look back to the 2020 CT, probably get a better understanding of what this is. So here's a CT from 2020. This is just multifocal lung adenocarcinoma, mucinous and non-mucinous, invasive, mixed mucinous and non-mucinous features.
That is impressive.
Yeah.
It looks so symmetric. It almost looks like eosinophilic pneumonia or something.
Yeah. I guess that would be a good differential for this peripheral.
Is it low attenuation on the soft tissue windows? I know you've got contrast on board, but yeah, pretty low there.
Yeah, that's a good thought for a differential for this. Yep. And then show one other one. This one is another one I looked at recently. Congenital cardiac case. So just a lot of interesting physiology here. The patient's now in their 20s, but she was she has a congenital cardiac history. She has pulmonary atresia with intact ventricular septum. She also has a tricuspid atresia. So she's been repaired. So essentially what we have now is this, it's basically a single ventricle physiology. We have a big LV, which supplies the systemic circulation, the aorta. So that's pretty straightforward. Obviously, she needed some supply to the pulmonary artery since the pulmonary atresia. So she, shortly after birth, she had the Glenn shunt done here. So SVC to SVC or subclavian to PA, widely patent Glenn shunt. At some point, she got pulmonary RPA, right pulmonary artery stenosis, and she has a stent here, which is also widely patent. Unfortunately, after the Glenn, she developed increased resistance in her circuit in her pulmonary artery. So that precluded a palliative Fontan completion. So she was just left with the Glenn, and if you go down, the IVC still drains into still connects to the RA. So there's no Fontan here. They did, however, put this other shunt here, which is called a POTS shunt, and that connects the RPA, or it's classically done in the LPA to left pulmonary artery to ascending aorta. And this functions as a right to left shunt, so it decompresses the high pressures in the right pulmonary artery and dumps them into the aorta, which is lower pressure. So this basically simulates an Eisenmenger syndrome, which in this case is more desirable than letting the PA pressures keep increasing. So there's that, and then also over time, with the increased systemic venous pressures with the Glenn shunt and pulmonary hypertension, she develops a lot of venous collaterals in the chest wall. Some of them are already coiled here, and just an interesting or good example of transpleural collateralization here from the mediastinum or chest wall here into the venous collaterals into the pulmonary circulation, and that eventually dumps into the lower pressures of the left atrium. So that's another. So we have that's another right to left shunt. So we have the POTS shunt here, which is right to left, and then these shunts here in the lungs. So predisposing the patient to cyanosis. And then the last interesting finding is this very large RCA. And so if you follow the RCA, this meets criteria for aneurysm. If you follow it down, you can see a fistula here with the RV. So she's developed fistulization. Essentially, the RV's blind ending, so there's no outflow tract, and it develops really high pressures, and then that causes fistulization with the RCA, and then the flow is reversed. So from the RV to the coronary, so flow, RV dependent coronary circulation is the term how this has been described. That's it.
So the POTS was originally a left pulmonary artery to descending aorta.
Mm-hmm.
So I didn't realize that they would ever apply that terminology to a ascending aorta to right pulmonary artery, anastomosis.
Yeah.
So it's basically aortopulmonary artery anastomosis, but I thought POTS was just descending aorta.
Mm-hmm.
And they sort of fell out of favor because it was really difficult to regulate the amount of blood flow, because you had this, these big pipes and stuff like that. It was hard to get the right amount.
What year did it fall out of favor?
Well, I think
around what time, I guess.
I remember seeing some cases back in the 80s and 90s, but I don't think I've seen it since then.
Yeah.
And by that time, I think it was already not being done very often.
Yeah, so that makes that's kind of consistent, because I just did some research into it, and I did see where it was mentioned in like the 70s, 80s, they were using it, and then that's probably when they were doing it to the descending. But I recently read that it's been it's picked up again, like within the last 5 years. They've been using it to improve pulmonary hypertension. I've seen some recent papers on it. So I think it's kind of, they're reviving it. And I'm not sure if they're doing it for another, but the purpose they're doing it now is for pulmonary hypertension. I'm not sure
Right.
what
So
else
that's a different purpose. So I think, you know, it's been rediscovered maybe for that purpose.
Yeah.
But in the old days, what they found was the Bacillus was the better palliative shunt because the subclavian artery diverted to a pulmonary artery would deliver about the right amount of blood flow. So it was, you know, it was intrinsically properly regulated. It was much harder to get the right amount of blood flow when you had a hole in the aorta connecting to a pulmonary artery.
And then so this is now the opposite way. So they're trying to get flow from the artery to the aorta the other way. Yeah, so I didn't see in any of the literature a connection RPA to aorta. Everywhere it said LPA to aorta, and even in the notes it said that the patient has a left pulmonary artery to aorta shunt POTS, but that's not what it looks like in the images. So I think the surgeons just decided arbitrarily to do it on the right side this time. But yeah.
Peter, I had a question about that coronary fistula. So
yeah,
so it's now retrograde flow. So what's the long-term sort of outcome for that coronary, since that RV is so like small?
So the RV actually has the RV actually gets really high pressures. So the problem is that so there is good pressure in supplying this coronary from the RV, so that's not a problem. But the problem is if you decompress which they are doing it in a way with this POTS shunt, they're decompressing the right circulation, you can get steal from the RV. So since the RV is being decompressed, the flow can reverse from the coronary into the RV through the shunt, and so that'll just cause steal, and that can cause steal from basically from the coronary perfusion into the
Okay, that makes sense. Thanks.
Yeah, so the flow will start going into the RV instead of out of the RV into the coronary circulation. But yeah.
Excellent cases. Those were fun.
Yeah.
All right. David or Travis?
Can I go next, because I'd like to bring up a case apropos of one of the cases you just showed.
Absolutely.
So let me show you this this young man. This is a case I've been puzzling over. I was asked to look at this case. This is a roughly, I think, 38-year-old man, fairly young man who doesn't have any bad habits and has this diffuse lung disease. This is January, and his history is that he was put on Humira for what was thought to be maybe ankylosing spondylitis, but the serologies were a bit ambiguous. And he got a little short of breath, and then he developed this sort of chest radiograph, and he had some imaging around this time. Let me show you these thin sections. And he has a lot of lung disease. It's ground glass with lots of septal lines, tons of septal lines, and this sort of bright border here posteriorly, sort of isolating this, so it seems to be floating away from the edges of the lung, but there are lots of septal lines down here too. So the other thing he's got is a ton of lymphadenopathy, and it's sarcoid-like lymphadenopathy because it's very well-defined nodes with no blurring into the fat. So these are not soggy nodes that would go, say, with lung edema. They're very well formed, very crisply marginated. So this is just great for sarcoid. And we don't have older imaging to know how long this lymphadenopathy is there. I'm hoping maybe there can be some old imaging. You think a guy with a diagnosis of ankylosing spondylitis would have had some sort of imaging. Maybe we can get a hold of that, but for now we don't have it. So he was taken off the Humira because I'm not sure why he was taken off, but he he got short of breath, and then he has this lung disease. So I find it very hard to attribute this to Humira, unless it's a sarcoid-like reaction, and what he really has is a ton of lymphadenopathy, and lymphadenopathy is backing up lymph into the lung like this, and what we have here is really lymphedema with ground glass and lots of septal lines. So he was put on steroids for a month, and then he got better. His lung disease got better, and let me show you this. I'll flip this over for you. So after a month of steroids, you can see that his diffuse lung disease has actually decreased. The number of septal lines has decreased, and his lymphadenopathy has regressed quite a bit too. It's not gone, but it's much smaller. So again, I was thinking, could this really just be lung edema that's backed up because of this lymphadenopathy? Also, I thought, could this be Castleman's disease? Could this be Rosai-Dorfman with lots of lymphadenopathy and stuff like that? But so, Jeff, I remember some cases of lymphangiectasia that you showed. That's why I inquired about that yesterday, and you sent some cases. They were similar to this pattern with ground glass and septal lines. They were patchy. They weren't as there wasn't as much of this as before. He's had lavage. There was nothing remarkable on that. He did not get transbronchial biopsy. He's scheduled for axillary lymph node biopsy next week. And if that's not revealing, then he'll probably get EBUS and sampling of that subcarinal lymph node. So we'll see if this is all being driven by his lymphadenopathy. It was not alveolar proteinuria. It was PAS stain negative. They just got, I think, normal cell counts. I don't think there was an abundance of any particular kind of cell. But you mentioned storage diseases a minute ago. I came in late, but Peter was showing that Niemann-Pick case. What do you think about that as a possibility for this? I really need help from you guys for figuring out what this is. It got better on steroids. This is better than before. It's less dense, fewer septal lines. Well, and then once he taken off the steroids because he didn't like the effect on his and his muscle wasting, it all came back, and it's now as bad as it was in January.
Well, David, I would argue the improvement argues against a storage disease, since steroids don't make that enzyme magically appear.
I was hoping maybe they did. Okay.
So
how old is the patient?
He's in his 30s. He does not have bad habits. He does not vape.
Yeah.
And he doesn't do crack. And there was no blood. It was not hemorrhage. It was not alveolar proteinosis. Normal cell.
Jeff, go ahead.
I was going to say, well, drugs like Humira, I mean, can cause sarcoid-like reactions.
Yeah.
And so I agree, those lymph nodes look kind of sarcoidish. They were plump, potato-looking nodes. But you don't really see very lymphatic distribution in the lungs. So if it was all lymphedema, but if the lymphadenopathy it's gone. You'd expect the lungs to get a lot better, because that lymph should clear out pretty quickly. If you think about how quickly people clear their lungs with heart failure with a little fine tuning.
Right. Okay. So no.
The other comment, David, is that the storage diseases usually present in childhood or adolescence, so he's a little old for that.
Right. Okay. So so you guys are joining the head scratching club.
Did he have a bronch? Sorry, I just joined. He had a bronch, which showed what?
It didn't show anything. He had lavage, and there was no remarkable cell count. And it was not alveolar proteinosis, PAS negative. It was not hemorrhage.
It was just completely normal. Was there a lot of macrophages? I mean, they just said kind of.
I don't think there were lots of macrophages, but I'll be in touch with a pulmonologist again and try to collect more history. So, and there had been something in his blood. There was a sort of a borderline IgG4, antibody, but borderline. And the serology IgG4 is not particularly helpful. Echo, by the way, was normal too, so it's not heart disease backing up into his lung.
He has no pulmonary hypertension or anything like that. His PA is completely normal in size. His right heart's normal in size.
They said that his echo was normal, but I have not.
No, they said his echo's normal.
This pulmonary artery is biggish here. This PA is a bit big.
And did he have kind of the confluent hilar stuff, like the confluent hilar lymphadenopathy?
He had hilar and mediastinal lymphadenopathy. Let me show you the earlier study here. You see he's got lots of hilar on both sides and mediastinal nodes, big subcarinal, and juicy nodes up high in the mediastinum here too.
Well formed. I was thinking.
Yeah, well formed. So I was thinking, could this be Castleman's disease? Could it be Rosai-Dorfman?
Oh, that's a good thought. I mean, they do get, but it went away. But they do get, can get pronounced septal thickening. Amyloid, sarcoid, Castleman. Again, I've seen a couple cases of PVOD look-ish, but the lymphadenopathy is not right for that. That's usually more kind of a
right, soggy, smudgy nodes.
Soggy, yeah, these are well defined.
Okay. Can you show the lung windows again on the first one? Was there? And
oh, that's really pronounced.
I'm not sure if it would make any clinical sense, but PCP was at some point was ruled out.
Yes, and his he's not, his presentation doesn't fit with that, but yeah, cultures were negative too, I think.
Part's totally normal. Yeah, I don't know. I mean, it looks fluidy. It just looks like fluid.
It does, doesn't it? Really looks like something backing up in the lungs, but yeah. Okay, guys. Well, thank you for not making me feel ridiculously inept.
And just to your comment about like Rosai-Dorfman, that wouldn't go away with steroids either. I wouldn't. So.
Well, it might.
Yeah, but that pronounced. I mean, usually it's a progressive. And that, what was the time frame between the two scans?
Well, just a month.
Yes, I don't know.
Okay.
Open lung biopsy.
I think that's they've got that in mind. Okay.
Yeah.
So let me show you a different person now, and this this is a woman who was getting chemotherapy for myeloma and developed this blob in her lung. So she's neutropenic, and you can see she does have this consolidation here on the lateral view, and you can see here on CT it's fairly compact consolidation. So when I see compact, I think of fungus, but it's not really forming a nodule. But if you told me that they got mucor out of this, I would say that's just fine. This would be great for some sort of zygomycete or aspergillus even, or nocardia. Those are my choices. And then in terms of bacteria, I would throw in, besides nocardia, the possibility of Legionella magdatii. It likes to form compact masses that look fungal. So sort of ambiguous here, fungal versus bacterial. And there are a couple of other littler things, but not actually. That's probably just atelectasis. It's nothing too striking. So they got an organism called Bacillus cereus. So it's not spelled S-E-R-I-O-U-S. It's C-E-R-E-U-S, which is explained to me as referring to cereal, like something that would be on plants or in food. But it's actually cereus. It really means waxy in terms of the way the colonies look. So that the cereus is not referring to cereal grains, but to the waxy appearance of the colonies of this organism. And it has a lot in common with anthrax bacillus. It has a very similar genome evidently, but it lacks a couple of enzymes that make anthrax even worse. So this organism is a common cause actually of
food poisoning, right? Isn't
rice.
Fried rice.
Fried rice. Remember that old book we all read in medical schools, like reheated fried rice?
Yeah, I encountered that yesterday, but I have a feeling that's only one presentation. Most people are not It's
No, I know. It's just something like I think most people in medical school use this.
What was it? Ridiculously simple? God, it's
Yeah,
been like 20
that.
years.
It said like, "Oh, be serious" from fried rice, and
Yeah.
that's the one thing I remember from medical school 12 years later, or 16 years later.
So
Okay.
I just did a quick Google. 63,000 cases of food poisoning per year estimated caused by B. cereus in the U.S.
right.
Food poisoning. There you go. Yeah.
And it's fairly hard to treat. I think she's getting vancomycin for this, and it is getting better. So follow-up radiographs show improvement. The other thing, it causes a skin disease too. So there's a lot of cutaneous versions of this thing too. So this is the first time I've ever encountered in the lung, and she's improved quite a bit on her most recent chest radiograph. So my first case of this serious lung pneumonia here. Okay, guys, thanks for your help.
Yeah, good stuff. All right, well, let's see. We got Travis and Seth.
I've got a couple. I can go whenever.
I'm working from home. I don't have any cases anonymized. I can try if there's time, but
Okay. I've got 3, so.
You should see a radiograph here.
Yeah.
This is a fairly quick one just because it's rather dramatic on the CT. You know, we all know that the aorta can hide on radiographs. In this case, it's not necessarily hiding. There's this abnormal right mediastinal convexity, and maybe it's a dilated esophagus or somebody that has had a gastric pull through for esophageal cancer. That's not the case here. So have to wonder about an aortic aneurysm. This guy, I think his history, I put this together a couple of weeks ago. Let me pull it up and see. Yes, 6 weeks of palpitations and chronic cough. And interestingly, his brother passed away a year ago from a dissection. And here you will see, this is definitely in the top 2 of the largest ascending aortas I've ever seen. And he also has findings of a chronic dissection. You can see that there's a lot of calcium in the wall here and some mural thrombus. And what's interesting too, and they only briefly commented on this, but it looks like he has an intimo-intimal intussusception up into his arch vessels. And they did comment that there was like a complete circumferential intimal tear into the arch vessels there. But
that is a big one, man.
Yeah, I know. The degree of mass effect on his left atrium, surprisingly, he's got like a tiny bit of pulmonary edema, maybe from just chronic venous pressure increase from that mass effect of it, but it's compressing the pulmonary arteries as well. So
does he have a bicuspid valve by any chance? I mean, is he like a marfanoid?
They were evaluating him for that. They didn't comment on being bicuspid. Let me look really quick.
Probably not. I'm just curious.
No, it's a good thought. I mean, especially with his brother passing away a year ago from a type. Now it's tricuspid. But
He's got regurg.
I'm surprised he doesn't have more symptoms like from regurg, because you can see there's complete lack of coaptation there. His LV is a little dilated, so he probably has a significant amount of regurg. But
Travis, how does his descending aorta?
How does what?
How's the descending aorta? Does this go away?
Descending aorta looks okay.
So, I mean, this is the classic pattern of Marfan's, which is, these used to be called a type 1 aortic dissection. The DeBakey classification, which was usually Marfan's, is limited to the ascending aorta. How old is this guy?
40, I think he's 42, and 41. His brother passed away. Yeah, so it's some sort of elastopathy. I agree. They haven't finalized the workup.
How about Louis Dietz? If it's not Marfan's.
Yeah, right. Or the vascular type of Ehlers-Danlos, maybe. I don't know. We don't really see his vertebral arteries to see how tortuous they are. But yeah, I agree. This is some sort of genetic thing. So this is an interesting case, and I think Howard's probably shown the most cases of this type of phenomenon, but this is a patient who came in a few weeks ago, was found down. And I'll start with the lungs, because within the last year, I've shown there was that nice paper in the radiology cardiothoracic imaging describing that sign of like the dependent lobule sign with pulmonary edema, where basically fluid is just dependently layering in individual pulmonary lobules. And this is a guy who had a cardiac arrest and was found down. So this is all, or most of this is edema. You can see it's kind of like, you can imagine the fluids just layering within each of the pulmonary lobules. And then of course there's an overall gravitational dependency for the lower lobes. But of course the contrast enhancement is the curious part, because he has contrast in the vena cava and in his right atrium and in the coronary sinus, and then it completely skips the heart. And then there's a contrast fluid level with some smoke in his ascending aorta and in his descending aorta and all the way into his abdomen. So this is somebody who, unsurprisingly, is on ECMO, and this is veno-arterial ECMO. You can see the venous limb here. And so I think this is one where they injected through the upper extremity. The venous blood is taking that contrast out, and then it's coming back in via his femoral artery, which is why you have contrast in the descending aorta. And he has a venous phase through his abdomen and pelvis as well, where you can see there's a little bit more contrast. Still, really nothing going through his heart. His heart is not working, but you'll see there's a femoral arterial line right here, and this is where the contrast is going in. So I show this because it's interesting. And I've been reading about different patterns of ECMO, and in patients with veno-arterial ECMO like this, there is a risk of what's called Harlequin syndrome or north-south syndrome, or just watershed infarct. And it's really competing, because blood should be flowing backwards in these patients that have cardiac arrest like him. So he at least has some perfusion of his arch vessels, save the right carotid artery here doesn't really get much flow. Because there's no competing forward flow from the aorta, or sorry, from the left ventricle, because his heart's not working. This is a really nice article that I found a review, and I'll just show you quickly the diagram where they talk about this. And the idea of it being Harlequin syndrome, because if patients have competing flow with any residual ventricular function, it's this one, then you can have forward flow of deoxygenated blood to the upper extremities and the head. And you can have the, running into this watershed area, and this varies based on their amount of cardiac output. So in this guy, clearly there's no real competition, because his left ventricle was completely non-functioning from his large infarct that he had. So in this case, the oxygenated flow was getting up into the upper extremities. But I hadn't heard the term Harlequin syndrome before I was reading this, and I thought, it's just a nice, interesting physiologic example of difference in flow. And I pulled up this old case. I don't think I ever showed this, but this was a few years ago. This was another one. And that article specifically talks about the competition in the left ventricle with forward pumping in a case like this, where you have something like pulmonary embolism, where the right ventricle may be failing, but the left ventricle may still be pumping. Now, in this patient, they were also on veno-arterial ECMO, and they have still the same thing, but you can imagine how the watershed area could be in the arch, or could be even a little bit more distal based on the amount of flow that's coming forward from the left ventricle. And this one's very similar. Or actually, I don't know. I hadn't looked at this guy's lungs in a while. This one looks like it's more chronic. He's got like some lung injury here. I'll have to look back at that. But just two examples of bizarre flow from veno-arterial ECMO. And Jeff, I will stop there.
All right, well, that's cool.
That was the first one that you showed. The ventricle is pretty dilated. You think that's from the ECMO? Because we've shown some cases where you need to decompress the LV. Where they put or is that from the infarct, or both?
No, that CT was done when he was in the ED. Like, okay. He came in asystolic, was resuscitated in the field. That was relatively acute. And unfortunately, the patient passed a few days later, never regained function.
All right, let's see here. Okay, so I'll show a few here.
Jeff, I have two cases at the end if you have time, if there's time. But
yeah, we should have time. Mine shouldn't take very long. kind of a slow week here. All right, not slow volume, slow interesting cases. Okay, so this is just a nice example of something we don't always pin down a diagnosis on. So this is a heart transplant recipient, and you can see hearts there, and there's clearly abnormal looking lungs. There's, sorry, background noise here. A bunch of opacity in both lungs, and it has sort of a nodular consistency to it. We don't really see much in the way of pleural disease, and it's sort of a basal predominant. So this is the patient's CT scan, and we can see there's a lot of emphysema, but you'll notice there's a ton of tiny little nodules, but they're very fuzzy. A lot of them are very fuzzy, but you can make them out there, and they're sort of randomly distributed, and then maybe a little bit more confluent area. And then as we get down, there's some debris in the airways, and then there's this consolidation here in the left lower lobe, and some probably dependent atelectasis, no septal thickening really. So this patient had rip-roaring CMV viremia, and so the presumption is this is CMV in the lungs, which can present as small nodules. Interesting, the patient also grew out some aspergillus in the BAL. So I don't know if this is the aspergillus or not, or if it's one of those ones where they just find it, but there's really no imaging. I'd be happy with he may be aspirated, or this is just some stuff distal to that mucus plugging. There is some volume loss, or it could be. But I'm pretty confident that most of these tiny nodules fit with the CMV viremia. I'll put the coronals up and make them MIP real quickly just to bring them out a little bit. But you can see all those tiny little nodules there. So that's been my experience with CMV. We often don't pin it down, and it's often sort of a presumptive diagnosis. But given I had a hard time making this all aspergillus, especially since I don't think he was that sick from it. So I don't know, David's probably seen a lot more CMV in the past.
I have seen miliary disease from CMV.
Okay.
So this,
yeah, I think it fits. So the patient's being treated appropriately for that. All right, this is just kind of a classic case. It's a good medical student, first-year resident case, but it's one I got path on in multimodality imaging. So this patient has this mediastinal mass here, and you can see it's separate from the right heart border. So it's not in the prevascular space, and on the lateral view we can localize it nicely in that subcarinal region. So most of the time we see these as bronchogenic cysts. I like to just call them foregut duplication cysts, because this case will illustrate they're not always bronchogenic, but you can see it's got just a sort of a little bit of a capsule to it, but it's low attenuation. But it has some pretty pronounced mass effect on the esophagus right there, and sort of it hugs it as it sort of descends down there. And then a really nice esophagram image here that shows the fixed extrinsic defect with the obtuse angles here, showing that it's not, well, we know from the CT that it's not in the wall, but if the patient had dysphagia or anything, you would know it was an extrinsic lesion. And so this was resected, and it was actually an esophageal duplication cyst, so it had esophageal mucosa. So the point being is that we classically think this is the classic location for so-called bronchogenic cysts, but really they're all duplication cysts. And a nice little pulmonary vein anomaly here, a top pulmonary vein coming in. I know Howard's shown a bunch of those. So there's that one. And then this last case is kind of a fun one that we encountered yesterday. It goes way back when. So I'm going to start with an old abdominal radiograph. And you'll notice on this radiograph, there's some funny calcifications up in this right upper abdomen or lower chest. And then here's a more recent portable radiograph. You can see that this persisted. And these were years and years apart. And this patient has had trouble with his kidneys. So they did it way back when. This is a renogram, for those of you who remember these. So they, I forget, they do perfusion, they look at uptake and as well as excretion. And you can see clearly this right kidney. And so what the convention is, you do these, the left is actually on the left, so it's a posterior view. And the ROI here shows that this is a non-functioning right kidney. But what's kind of cool is if you watch the cine loop, which will be up in this upper left-hand corner. So let's see if I can get the cine loop to play. You'll notice, so there's uptake and excretion in the left kidney, and you see it into the bladder. And then there's a little bit of liver and spleen uptake early, but notice there's no uptake in this ROI here. But look right up here in the corner towards the end, you'll see there's uptake. So what happened was when that nuclear medicine study was done about 8 years ago, whoever the technologist, whoever prepared it, missed the fact, because there was no cross-sectional at the time, that the right kidney is actually in the chest. So this is the right kidney here, and you can see it's got very thin parenchyma, very dilated calyces in the pelvis, and then these large stones in here, so staghorn stones in that right kidney, which is just barely functioning at that time. And then the left kidney is actually where it's supposed to be. So going back to the nuclear med study, the right kidney is actually outside the field of view, just we catch a little bit of it very late right there. You see that uptake. So a intrathoracic kidney, and if we going back to the CT again, usually they enter through a Bacillus hernia in the absence of a traumatic diaphragmatic defect. And you can see if we come down to the diaphragm, there's the crus. So it's a healthy looking crus, but there's a sizable defect back here, because if you compare to the other side, we can follow the diaphragm around. There's just a huge defect in this general vicinity, and so the kidney has somehow managed to work its way up in here, taken all the perinephric fat, vessels, and it's been there for a long time, but we see it going back years. It's been kind of chronically obstructed because of this. The left kidney is in its normal location. So that was just kind of a fun multimodality case where,
Jeff, do you think the Bacillus is the primary lesion and the kidney got calcified because it was ectopic and things were torqued or something, or?
That's what I wonder. You would think about that, because if you look at the neck, if you can figure out, this looks like the ureter maybe somewhere down in here, that maybe it was a chronic sort of, not quite a UPJ obstruction, but functioning like a UPJ obstruction, that the kidney became sort of chronically obstructed, and then that led to stasis, parenchymal atrophy, and stone formation. I would think that would be the most likely thing, because that's a pretty small defect for such a big organ. Let's see if we can look at it on a different plane. Yeah, it's pretty tight in there. But I didn't have anything older, but this goes back about 8 years of imaging. So it's been sitting up there and mostly non-functional.
It probably is torqued around and twisted too. So
yeah,
that could contribute to some obstruction.
Sure. Yeah, because this stone isn't as big as all of this area there. So yeah, it was just kind of a fun case. So another fun one for a medical student or a first-year resident, recognizing these unusual calcifications, because you may think this is contrast or something in the liver, but in reality, it's all kidney. Okay, well, that's all I have this week, so I'll turn it over to Steph.
Hold on 1 second. Let me just pull these up. Okay. Trying to pull over a little bit of a better view of this. Unfortunately, like you say, when you're busy and you're not really checking stuff before patients get off the table, you feel stupid. But the tech called me and said, oh, we had a case of an old woman that was here for viability study. And I was like, okay. And wasn't thinking that much of it. And just the fact that there's dextroposition, I figured she had a lobectomy or something. Anyways, that's not the case. You can see there's also a left-sided SVC here, and there's no bridging vein, but I think most of us can kind of see or recognize that the right lung is small. There's no evidence of resection here. And here's this kind of wandering, well, not really wandering, this anomalous vessel that is coursing down. And I'll show you some other views. I was trying to pull over the one view that really showed it well. I just couldn't get it completely anonymized in time. Oop, that's not the plane we want. So this is, of course, going to be scimitar syndrome. And what you can see here is there's this anomalous vein that is going to come down and drain into the IVC down here. I have to say, I've seen this, I don't know why it is, but I've seen this a lot in older asymptomatic women. I don't know why that is, what the underlying reason for that is, but let me try to find that. This may be not the best view, or this is all somehow upside down all of a sudden. 1 second. let me pull it up. There's one shot where you can nicely see the reason why I think a lot of these patients wind up in some asymptomatic, in my kind of going theory on this, is here you can kind of see a little bit better. But on the cases that I've noticed that patients are asymptomatic, and again, I've seen this a lot in specifically older women. I don't know why that is. The draining vein, that the anomalous vein that drains into the IVC, it gets extremely tight and narrowed as it kind of goes across the diaphragm, and it gets compressed as it kind of ducts down. So it gets compressed between the cruce of the diaphragm and the IVC coming up. And that, I'm trying to find the one that really showed it well, and I'm never going to be able to find it. That vessel gets really, again, compressed. And because of that, you're not having the significant shunting that you would expect to see. I can't find it. But anyways, you don't have the significant shunting. So I don't know. I don't know how, I mean, we see this occasionally, and just because I don't do a lot of peds anymore, the majority of cases do happen to be in asymptomatic adults. I don't know what other people's experiences on these cases, if they, of course, we see them in patients who are younger who have a significant shunting, but if you've noticed that compression of the anomalous pulmonary vein in the IVC, if it ever looks compressed, and if you've seen that more in the older asymptomatic patients.
But Seth, the other thing that could be operating here is when that lung is so maldeveloped that it's this small, there's not a lot of blood going to it anyway, and so in a way there's not a lot of blood that needs to be shunted. So by the heart's twisting way over to the right like that, the left lung is doing the work of the left and most of the right lung too.
If you look at the vascularity on the right, it's definitely not as pronounced as on the left.
Right.
But we do see kids that come in with this. I mean, we have cases of young kids who come in who are, I mean, when I used to do peds congenital, who were 5 or 6, who came in with a significant shunt. And just from my memory, those kids had a big vein draining kind of smack into the SVC, either clearly below the diaphragm or above the diaphragm. And the recent cases I've seen in the asymptomatic older patients, that drainage was almost at the cruce where it was getting very narrowed. But you're right. I mean, this is not a normal lung, and it's by no means getting half of the blood flow. I mean, it's probably getting 10, 20% of the blood flow. But just an observation I had seen, and it was just a case I really wish that I was paying more attention when I saw the localizers and before the patient got off the table. But again,
well, Seth, we've collected a fair number of scimitars through this webinar over the close to a decade now, I guess. I think I've had all the ones that have been shared. We could definitely go back and look at them and see if we see that in the female patients. Probably have, I don't know, 15 or 20 scimitars at least.
Yeah, it'd be interesting because again, in my experience, the majority are really asymptomatic older patients, and Dave is probably right. It's probably the fact that the shunting is not that dramatic.
Mm-hmm.
This is a case that came in as a resolving PE, and I think, well, some of this you could look at this web, and again, I have to write this paper up. We now have so many sarcomas. My going theory is once you see a web, you should be pretty convinced, but that it's not a sarcoma. But now I'm gonna have to change that and say if it's a web that's remote from the actual primary mass. So this is this patient's going to surgery. You can see that this vessel is, this is not, he doesn't dramatically expand the vessels. There's vessels actually coursing through the mass, and you will see some areas that are occluded. This is going to be all tumor. The interesting thing about this one, I have to say, of the 50 or something, maybe close to 60 I've looked at now, I haven't seen one. This is the first one I've seen that we see them crawl across midline, but it's the first one I've seen really crawl across midline. You can see the soft tissue component towards the valve. In the main PA, that's a pretty good sign, although not, I've seen plenty of CTEPH do this as well. But the expansion going into a lobar and segmental vessels on the other side, usually it's, you know, tumor on one side and then creeps towards the other side and expands the other side. But this one is really, really quite bad. And, you know, and even the ones, I have to say, even the ones that look like they're really unilateral, if they're in the main PA, you know, our surgeons will say, and they do say, that everyone that looks like it's localized to a single PA, or even, you know, extending towards one main PA, they're almost always bilateral when they scoop it out pathologically, because it grows along the intima. Even though there's these big soft tissue components, a lot of this winds up being tumor and clot. But because this grows along the vessel wall, you get spread along the wall of the vessel, even in areas that look relatively spared. So this hasn't gone to surgery. It's not confirmed yet. I would be surprised if this isn't a sarcoma. But our first, I think it's the first one this year. So just another mystery of the conference.
Ugly looking. But, ugly.
All right, those are my kisses.
Awesome. All right, well, everybody, thank you. It's just about the hour, so I'll talk to everyone next week. Thanks for joining in.
Thank you.
All right, bye, everyone.
Thanks, everyone.